All right, we talked about ACS, we talked about PE. Let's talk about the other deadly causes of chest pain. We're going to lump them all together in this last video. First, let's talk about pneumothorax. Spontaneous pneumothoraces usually don't develop into a tension pneumothorax. So if it's a spontaneous pneumothorax, usually it won't develop into a tension. The exception is when you introduce positive pressure to the patient. Any patient that comes to my ER that says chest pain, I'm going to get a chest x-ray looking for a pneumothorax. But if they're having chest pain, they're a little bit unstable, and then I put them on positive pressure, I may turn that into a tension pneumothorax. So the way we usually work this up is a chest x-ray. A quicker and more accurate way to work this up is actually with ultrasound. Ultrasound is far more sensitive than chest x-ray in determining and identifying a pneumothorax, and it's a lot faster. I can grab the machine and go in the room immediately and look for a pneumothorax, whereas with x-ray, I have to wait for them to come to the room, shoot the film to come off the monitor, and it's less sensitive. So this is the quickest way to evaluate for it. In the setting of trauma, these can become tension pneumothoraces even without positive pressure. If it does become a tension pneumothorax, if the patient is hemodynamically unstable with a pneumothorax, and at that point, you have to emergently intervene. The two ways you can do this are one, a needle decompression. I'm doing this the 4th, 5th intercostal space, inframammary fold, going in anterior axillary line or mid axillary line, and going with a needle, putting a large angiocath. Or I can take a scalpel, quickly dissect down to the ribs, and take an instrument and bluntly dissect, put my finger in there. As soon as I do that, that will relieve the tension. That's the quick management for a pneumothorax. The other life-threatening causes of chest pain we talked about were aortic dissection. Aortic dissections are very difficult because they can present quite insidiously. I have found a lot of type A aortic dissections on accident. You do want to do a history and physical exam thinking about dissection. Is it ripping, tearing through to the back with sudden onset? Kind of the worst chest pain you ever had. Do you have a pulse deficit? When I feel the radial pulses, is this one a lot stronger than this one over there? Do I have any focal neurologic deficits? If you have focal neurologic deficits with chest pain or stroke and chest pain at the same time, you need to be thinking about dissection. Look for dissection. You can do your echo and sometimes you get lucky. On a parasternal long, you get the descending thoracic aorta down there and onto it. On your apical four-chamber, you get the aorta. On parasternal long, you can look at the aortic root and sometimes see a dissection flap. You can do a sternal notch view on ultrasound and sometimes see the arch of the aorta, and that way you don't have to put the patient through a CTA. I will say aortic dissections don't always present classically. If you never miss an aortic dissection in your career, you have caused a ton of cancer because of all the CT scans you performed to make sure you never missed one. But keep your suspicion up. If you find it, if you find an aortic dissection, the two types are one, a type A and a type B. A is here on the ascending aorta. This goes to cardiothoracic surgery and this is an emergency. A type A dissection needs to go to CT surgery immediately. A type B or a descending thoracic aortic dissection can be actually managed non-operatively at times, but you need to emergently get them to vascular surgery, especially if you have something that's ischemic. So if you've cut off blood supply to a kidney, to part of your bowel, to an arm, to a leg, at that point it is emergent. Our management in the emergency department is first, we're going to get heart rate less than 60. This is our first priority. Before we worry about blood pressure, we want to get the heart rate less than 60. And the way we're going to do this is esmolol. This is an infusion, quick on, quick off, beta blocker. We're going to start the esmolol and titrate that to get the heart rate less than 60. After, and only after we have the heart rate less than 60, we're going to add an afterload reducer. So most commonly we'll use nicardipine. And we're going to titrate this to get the systolic blood pressure less than 100. Heart rate control first, blood pressure control second. That's going to be our ED management. Type A dissection, call cardiothoracic surgery immediately. If we can't do the surgery here, we need to get this patient out immediately, get their heart rate less than 60 first, and then get their systolic blood pressure less than 100. If we're keeping them here, type and cross them for a bunch of blood because they're probably going to need the OR, but this is a surgical emergency. Do a good history exam looking for it. Sometimes you can see evidence of a widened mediastinum, or you can see some abnormalities on chest x-ray that's not sensitive for it. Sometimes if you have a low suspicion for it, but you can't rule it out, some physicians will use a D-dimer to further evaluate for an aortic dissection. I'm just speaking from experience. They can be extraordinarily difficult to diagnose. They can present quite insidiously. They can present classically, diaphoresis, chest pain tearing through the back, pulse deficit, stroke symptoms. Sometimes they don't though. Sometimes they don't. So we talked about pneumothorax. We talked about aortic dissection. Let's talk about Boerhaave, or a ruptured esophagus. Usually with Boerhaave, this is from retching or vomiting. They'll have a history of recent retching or vomiting. Maybe they're an alcoholic that's been vomiting a lot that morning, and they'll have excruciating chest pain. It's usually the lower left side of the esophagus that's blown out with Boerhaave when it's from retching with vomiting. And these patients typically look awful. They're going to be diaphoretic. They're going to be sweaty. They're just going to look terrible. The treatment for this, or excuse me, the evaluation for this is a CT scan. You want to make sure you get a CT scan of the chest to see the esophagus, to see if it is actually ruptured. Once you have the CT scan and you've confirmed it, you want to call cardiothoracic surgery. You want to give antibiotics, and then you actually want to give antifungals as well. There's association between fungal infection and mortality. Maybe it's because those patients are immunocompromised. I don't care. I'm going to give antifungals because I know if they develop a fungal infection, their mortality is increased. So antibiotics, antifungals, and get them to a surgeon, get them to an OR. Now, especially in the days of an endoscopy in which we currently live, you can have some of these post-procedural esophageal tears, and they can present more subtly, and they can be more difficult to diagnose. If you don't see it on CT and you still suspect it, you can do a gastrograph and swallow. You want to do a water-soluble dye to see the esophagus, and that way if it leaks into the peritoneum, if it leaks into your mediastinum, it's not as big a deal. And then really the gold standard is endoscopy. Especially post-procedure esophageal tears can be more subtle. If you're suspicious and the setting of negative imaging, talk to your gastroenterologist. They may need an endoscopy to evaluate for esophageal damage. This is the basics of Boerhaave or esophageal rupture. Talked about pneumothorax. We've talked about dissection. We've talked about Boerhaave. The next one is tamponade. I don't really like this one, calling it a cause of chest pain, because usually this is secondary to something else. Whether it is severe myocarditis that's caused a pretty significant severe effusion, whether it's from trauma and your heart is actually bleeding, or there's a chronic dialysis patient that has a chronic effusion and now it's just tipped over to a sudden infusion, or type A dissections can leak back into the pericardium and cause tamponade. But we got to think about tamponade. The classic teaching for tamponade is you diagnose it by Beck's triad, which were muffled heart sounds, decreased blood pressure, and JVD. Beck's triad is garbage. It's based off of a case report written back in the 30s off of one patient. Its sensitivity for tamponade is like 30%. Know it for the test, but just in clinical practice, Beck's triad is garbage. The take home here is, if you're concerned about tamponade, really, if you have any unstable patient, hemodynamically unstable patient, and you're not sure what's going on, get your ultrasound out. Do an echo. You can rapidly identify this on echo if you have it. And then if you have tamponade, you need to do a pericardiocentesis. You can do this landmark, coming underneath the xiphoid, kind of laying your needle flat, aiming towards the left shoulder. You can do this ultrasound guided. You can actually get a peristernal view or an apical four-chamber view. And if you've got a big pocket of fluid right there with nothing overlying it, you can go in there and visualize your needle the entire way. But if they're in tamponade, you need to drain that effusion. And pneumonia, we'll talk about that in the shortness of breath lecture. Those are the deadly causes of chest pain that you need to be cognizant of for every patient that comes in the emergency department with chest pain.